Very good evening to everyone, and I welcome you to the 24th session of our this Powwow series. This month's focus is on Uvea. I now welcome Dr. Arshi ma'am, who is the moderator for today's evening, to take over the meeting. Over to you, ma'am.
Thank you very much, Astha. And again, a very good evening to all of you. A very warm welcome to all our panelists, our presenter, our fellows, our postgraduates, and all the other alumni who have taken the time out and joined this meeting today. So, today, basically, we are planning to have a discussion on two challenging cases of uveitis. And I would like to first introduce our presenter, Dr. Nivedita. So she has done her initial training from Trivandrum, and then later on she pursued a neuro-ophthalmology short-term fellowship from Arvind Madurai. And then, of course, she was a part of SN from April 2019 to September 2020. She completed her long-term fellowship in uvea and ocular immunology. Then she moved over to Trivandrum again and was working at Chaitanya. And since 22, she has been working in Bahrain. So, of course, along with all her academic work, which she's very proficient at, she has a keen interest in art, reading, fictional novels, and even cooking. So, a very warm welcome to you, Nivedita. And
Thank you.
yeah, I'm very happy to have you. And our esteemed panelists, Dr. Shishir Narayan and Dr. Vinita Rao, ma'am, a very warm welcome to you. So, both of them do not need any great introductions, but I just wanted to share the other side. Like, for example, Dr. Shishir, along with having the distinction of being one of the first fellows from SN to have completed his uveitis and ocular pathology fellowship. He trained later on in the UK, and since I think post 2000, he has been at Shroff Eye Center, Delhi. And along with his varied interests in the field of uveitis, he is also a vintage car restorer and loves to participate in car rallies. And a very surprising thing, which I was not aware was of, that Sir has graduated LLB in 2018. And Sir was very kind enough to share a few wonderful photographs with us, which show how time has passed since Sir has left SN. We can see Sir's photographs with Chief, with LG Sir, and with JB Sir here as well when he passed out. So, a very warm welcome to you, Sir.
Thank you. Thank you for your kind introduction. Can you hear me?
And yes, sir, we can hear you. We can hear you. It's slightly on the lower side, I think, your volume, sir, but we can hear you.
I was very soft when I said so.
Okay, sir. And I would like to welcome Vinita ma'am. So she has completed her post graduation from SN in '98, and she was working at Sri Ganpati Netralaya post that, and she's been working as a senior consultant here with us at the Department of Uveitis at SN. She is one of the founder members of the USI, and of course, she is a keen researcher. She has presented multiple papers and posters, even at multiple international platforms. So, we are very happy to have you today evening, ma'am. A most welcome to you, warm welcome to you.
Thanks.
And with this, I would like to give over the podium to Nivedita. So she will be presenting two cases today. And once the first case has been presented, we can have a short discussion on the same, on the salient points before we move over to the second case. And once the second case is completed, we will also be able to take questions from our audience. So please do send in your queries. Thank you.
Thank you so much for the opportunity, ma'am. I'm privileged to be presenting in this UVA meet, Power 24 session on challenging cases in uveitis. So I'll delve first into the straight into the case. So this is a 78-year-old gentleman who presented with sequential vision loss in the left eye of 20-day duration, followed by his right eye of 4-day duration. He had associated severe headache, pain, redness in both the eyes, and for his headache and other neurological symptoms, he was admitted at the neurology department and he was referred to us for the ocular examination. He is hypertensive. He has autoimmune vitiligo since 20 years and hypothyroid on treatment. So his best corrected visual acuity at presentation was in right eye 6 by 12 and 10 and left eye 6 by 18 parts and 12. The anterior segment examination There are multiple posterior synechiae. There are there are stromal iris nodules or Busaka nodules, mutton fat keratic precipitates, and anterior chamber reaction of 2 plus cells and 2 plus flare. There was NS grade 2 to 3 cataract. Um, on fundus examination, the view was not that great because of the cataract and the vitreous inflammation, but we could make out gross bilateral optic disc edema, but there were no obvious choroidal lesions or retinitis patch or vasculitis we could get from the fundus image, and no obvious or exudative detachment. On EDI OCT, we could see the gross optic disc edema in both the eyes. Macula was normal. So he was, since he was already referred from the neurology department, he had MRI brain, and that showed pachymeningitis, and CSF study also was already done, which showed pleocytosis. So we advised for other workup, and Manto test was negative. HRCT chest showed few hilar lymph nodes in the bilateral lung fields. However, the pulmonary fields were normal. Serum angiotensin converting enzyme level was 40.8, which was within the normal limits. This was a case of bilateral granulomatous panuveitis. So the differential we considered was Wakanagi-Harada's syndrome, because of the bilateral panuveitis and MRI finding showing pachymeningitis and CSF pleocytosis. Then ocular tuberculosis, ocular sarcoidosis, and considering his advanced stage, masquerade syndromes like lymphoma or metastasis. So management, we started him on IV methylprednisolone 1 gram per day for 5 days, followed by tapering oral steroid, and he had very good response to treatment. So this is post IV methylprednisolone, and the patient was on for 30 milligram oral steroid when this photograph is taken. So the anterior segment has quietened, and the fundus view is better. The optic disc edema is resolving. So he was on monthly review for 2 months, and the oral steroids were gradually tapered. Vision had improved to 6 by 12 in both eyes. But after this, he was lost for follow-up for 3 months with us, but he was on regular checkup with the neurology department. So then 6 months from his initial presentation, the best corrected visual acuity is 6.9 both eyes, 6.9 and 8 in both eyes. There was no active anterior segment inflammation or vitreous inflammation. On fundus examination, we could make out these nodular yellowish deposits surrounding the optic disc uh, in both the eyes. This is the left eye. So the surrounding the optic disc area, we could see yellowish nodular deposits. So on multimodal imaging, the IR reflectance image shows motile hyperreflective defects in the temporal to the optic disc. And in fundus autofluorescence, there is multiple diffuse stippled hyperautofluorescent lesions surrounding the optic disc area, suggesting an widespread RPE disturbance. Similar picture in both the eyes. It's much more pronounced in the right eye. So we went ahead with fundus fluorescent angiography and indocyanine green angiography. So for the right eye, this is the mid-phase image at 1 minute 06 seconds in the right eye, and 1 minute 23 seconds in the left eye. So the retinal vasculature appears normal. There is no vascular leakage or staining noted. However, in the optic disc area, there is hyper fluorescent lesions in the early phase of the angiogram. And in the late phase, it is more pronounced with staining only. There is no leakage from this lesion, and the optic disc leak is noted. In the corresponding ICG, we can see hypocynosine lesions in the mid-phase angiogram, and these posterior pole lesions are becoming iso-indents towards the late phase of the ICG. However, the lesion surrounding the optic disc is hypocynosine throughout the phase of angiogram, and this was similar in the left eye also. So we can see these in the OCT, the vitreoretinal interface is normal. The inner retinal layers were normal, but we can see these nodular bulgings at the level of the RPE with hyper-reflective material beneath the RPE, and there is increased reflectance behind these lesions. It is seen in both the eyes, these nodular RPE elevations. So, differential diagnosis for this suspicious sub-RP deposits, we considered infiltrative pathologies like ocular lymphoma, leukemia, or metastasis, or inflammatory pathology like tuberculosis or sarcoidosis. So, we considered further workup for this patient. We did tumor markers like CA125, CEA, and PSA, which were negative. We proceeded with PET scan, which showed multiple hilar lymph nodes in bilateral lung fields, and we proceeded with EBUS guided biopsy from this lesion, which showed granuloma suggestive of sarcoidosis. We took immunology consultation and started on mycophenolate mofetil 2 gram per day. And this is 3 months post starting mycophenolate mofetil. We can see the RP changes have flattened. There is no intraretinal or subretinal fluid. So my questions to the panel is how would we approach such a case like with sub-RP deposit? Whether we consider lymphoma early on in the diagnosis, and how we proceed with such a case.
So thank you, Nivedita. Uh, so as she mentioned, it was a case of a bilateral granulomatous panuveitis presented with disc edema and a lot of vitritis initially. And later on in the course of the disease, they have picked up some of these sub-RPE kind of lesions and RPE elevations. So, sir, what is your take on this case for now?
Should I speak? Ladies
Yes, sir,
first.
please.
Uh, okay, very nice case, Nivedita. So, sub-RP deposits, yes, that they are one of specific features seen in lymphoma patients. That is true, but you can also get it in other conditions, EB, sarcoid, serpiginous, multifocal choroiditis. All of them you can get sub-RP deposits also. But in isolation, I don't want to look at it in isolation. If you look at it in conjunction with all the clinical features, then you mentioned that the patient's age is around 78 years. So that is highly unlikely for the first attack of weak age. So amongst the granulomatous uveitis, that will be the last in my list. The next thing is he presents with pain and redness. You said a lot of pain and redness, more in favor of an inflammatory rather than an infiltrative condition. That is the next thing. Then in slit lamp, you said that the patient, usually the patient had posterior synechia. So one of the things which I have learned is that the posterior synechia is highly unlikely in infiltrative conditions. More in inflammations rather than infiltrative conditions. So these are. Then you also said about the FFA and the ICG. Now, if you're looking at something like, say, vitreoretinal lymphoma, the choroid is the last to be involved. But in metastasis, yes. But if you look at the hypofluorescent dark dots that you showed on ICG, the diffuse appearance actually goes more in favor of primarily a stromal choroiditis like PKH. But if it was isolated and more random sort of granulomas, then I would put it more in favor of a secondary stromal choroiditis like a sarcoid or a TB. So, having said that, your one of the investigations that turned up luckily and was negative. So again, peripheral energy that goes more in favor of sarcoid. That again, sarcoid on top of the list. Um, yeah, if the hilar lymphadenopathy is large enough and the pulmonologists do agree for endobronchial ultrasound and biopsy, that is good. So then you have a way of verifying. I think your question was when would you think of a vitreous biopsy? If the clinical features were more like if the patient had more of, say, presented with blurred vision rather than pain and redness, then I would consider more of infiltrative pathology or a masquerade which you want to do. Or if the patient did not have, say, had a mild anterior uveitis with no signing, that kind of thing, situation, I would have put lymphoma on top of the list and sarcoid a little lesser. Moreover, the patient did respond very well to steroids. So another thing which is going in favor of, and it stayed the response rate. So if the patient had a waxing waning course with steroids, then I would think of a vitreous biopsy. But you have to remember to hold off on the steroids for at least 2 weeks before you do a vitreous biopsy. That is my take on this.
So after Vinita's excellent synopsis, I think I have very little to add, which is my intentions anyway. But there are certain things I want, how I would look at the case. So let's look at possible differential diagnosis here, right? First thing is obviously you're looking at VKH. So the patient, I think, has vitiligo for 20 years, right? Then
Yes, sir.
the patient has got CSF changes and
Eos-
pachymeningitis, as you're
yes,
saying,
sir. Pleocytosis was there.
pyocytosis. So it can be that there is a very late presentation of the entire syndrome here. The third thing is the bilateral disc edema. Now, this is where it becomes interesting. When I was a fellow, JB, are we losing the signal or am I clear?
Yeah, you're clear, sir. We can hear you.
So young children get disc edema and older people get macular edema. So you have got a patient here with severe anterior segment signs. You've got synechiae, you've got iris nodules, you've got gross, huge disc edema. But if with all this, I don't get any macular edema whatsoever, there's not even a small cyst there. There's no cystic macular edema. My way of looking at it would keep the masquerade in the differential diagnosis, right? If there was some bit of macular edema, some PD, you see, even if there is no macular edema, the the OCT shows a very straight pattern of the entire RP choroidal complex. While the disease primarily is of the VKH is primarily of the retinochoroidal layer, RP layer. So I would have expected some waviness, even if there was no edema. You got an absolutely straight feature there. So it could be a neurosarcoid, which is the other thing. You've got anterior segment features, you've got hilar changes, and you've got bilateral disc edema, which can be there with sarcoidosis. So the differential diagnosis would be that of a sarcoidosis, and the pattern on the ICG showing the granulomas. So you can have that kind of a picture in an elderly. Now, having said that, I and Richa, I don't know whether she is here on the meeting today or not. We have one case of an elderly lady who had vitiligo for 20 years. She presented with posterior scleritis. After we treated the posterior scleritis, she developed a full-blown bilateral um, uh, uh, VKH-like picture. I presented this in last year in Chandigarh, this case. And then finally, she came up to have a leukemia, and it was picked up on the lymph nodes from multiple lymph nodes. And then for last 4 years, she has been on anti-cancer treatment, anti-CML treatment, and she's in remission. So your case of a 28-year-old patient with all the features suggestive of VKH, but no retinochoroidal changes and no macular edema will keep me very, very highly on masquerade or maybe sarcoidosis. Even with sarcoidosis, I would have expected some macular edema. Even when you have got intermediate uveitis, we all everything is guided by by macular edema. All our treatment is guided. Guidelines are based on 612 vision and the presence of macular edema. So I think that is a very important negative finding in this case. Archie?
And I had a question, sir. If there is no exudative detachment, can we diagnose like leakage? This is just optic disc edema. So there
So
is
here
no
actually,
retinal.
yeah, Nivedita, I was wondering if at your first visit, did you do an ultrasound or an FFA at the first visit? You shared some wonderful
Actually, this
OCT images.
patient, when he came for the first visit, that optic disc edema phase, it was treated by another consultant. So that time I was in SM. So when I joined back, the second
Also, these
phase
are
of
older
that.
images.
Yeah,
Ah,
so the second
okay.
phase where there is the deposits, that is the time when patients started follow up with me. So the first initial, like they kept VKH in first because of the neurological evidence, like neurology findings. But as sir said, it would be not in my first differential diagnosis, like VKH would not be a first differential other inflammatory because there is no exudative detachment in the retina.
And
So
they did not investigate the patient systemically as well at the first visit.
yeah, they did
So,
just the TB and angiotensin converting and HRCT, but I think that hilar lymph node that time itself was identified. So if we had proceeded further that time, maybe actually the patient was admitted to neurology. He was not under Oftel, so he just was referred. So the IVMP, all treatment from
was
the
started there.
neurology side there. So then actually we wanted an angiogram in the initial phase itself. So but patient once he finished the oral, then he came at 30 milligram oral steroid dose. So by that time the retina was clear, and then we didn't proceed with angiogram in that phase. Then when we noted these yellow deposits, that's when we investigated further.
So
So,
tell
but
me, did you?
I
Sorry.
wanted to just point out, sir, that do you think that these lesions which we are seeing on the OCT, these around the disc, these peripapillary lesions, they look very typically like what you would see in MFC, that RPE elevation, ma'am? What
Yeah.
do you think about that?
Yeah, so that's what I also felt, that there are other conditions also where you can get these kind of RP, sub RP deposits. So, and those clinically also, if you look at your autofluorescence picture, also was showing more like a those choroiditis, multifocal choroiditis kind of lesions. But definitely, the ICG picture shows a lot of those uniformly distributed hypofluorescent dark dots.
But the
Yeah.
again, the other surprising thing which I felt here is that even though we are seeing the ICG to be typically like that of a stromal choroidopathy, the OCT is not picking up any granulomas.
Yeah,
It is just showing us these RPE elevations.
yeah, which is why Dr. Carl Herbert always insists on doing a ICG, because
ICG.
he says that that is really the place where you can pick up the stromal granulomas.
So
So that means it is a full thickness granuloma, like the if it is hypocyanosin throughout the angiogram.
Yes, yes, these are the larger granulomas. Yes.
now I have monitored these lesions on OCT angiography. I don't think you've done OCT angio in any of these cases, because that what happens is you do an OCTA as a baseline, and then you don't keep on repeating the ICG or the FFA, and you monitor with the dose. So that is one thing you can add on in your armamentarium. Now Octa is available everywhere. There was a time when it wasn't, and this patient never developed any exudative retinal detachment even on the relapse. right? Am I correct, Dr. Niveta?
Yes, sir. Yes, yes, sir.
And the patient has not developed any sunset glow. So there is no RP pigmentary changes. After 3 months or 6 months, then a retrospective diagnosis of VKH can be made. But here, none of the features of long-term VKH are coming. So the initial presentation, your first diagnosis of VKH is absolutely correct, and you revise it to a sarcoidosis. And third, then you revise it further once you have these peripapillary changes. But these could be secondary to the disc edema that was there, and the disc edema is regressed, and maybe the RP is still showing changes, and they have gone away after your treatment. So that is an important
Yes.
thing. If these were masquerade lesions, I don't think they would have responded to steroid and MMF. Though in my patient also they have responded.
And
And
also, I
one
think in
interesting
masquerades,
article.
you would have probably seen these lesions throughout. In masquerades, particularly
Yeah,
lymphoma
that
deposits,
would have been first
they
thing.
would, yeah, they would be subretinal, intraretinal. You'll have multiple level lesions. Here it is typically the RPE, and you are seeing that hyperreflectivity of behind them as well, that transmission. So to me, it
Yeah.
looked more like early MFC kind of lesions, and they have also responded to the treatment. So
Yes.
probably
The only
sarcoid.
thing, yeah, the only other thing is if it's a CNS lymphoma and the disc edema is regressed and the metastatic cells have traveled down through the optic nerve on both sides, giving you a symmetrical picture. And the edema was the one which facilitated. That is the only thing that you can consider in your CNS lymphoma with a secondary, not a primary intraocular lymphoma, because that would not be the place or position for it.
And one interesting article I came across is that in sarcoidosis there is sometimes transition to lymphoma later on. Like patient who is a biopsy proven sarcoid, sometimes they can progress to a lymphoma later on. Like median, it is called sarcoid lymphoma reaction. So some around 2 years gap, like 24 months they have noted. So it can progress to lymphoma. So basically, we need to follow up this patient for developing
Yeah.
lymphoma.
At any point, if you see
So
that
I think it's a good discussion.
at any point if you see that the it is not responding to the steroids, or the inflammation is tending to come back, at that point, before you start the steroids, or keep the patient off steroids for 2 weeks before you, if at all you want to do a vitreous biopsy.
By
Yeah, keep in mind that the patient is off steroids for some time when you do the vitreous biopsy.
yes.
Ma'am, sir, any further points you would like to add, or shall we go over to the second case for now?
And just one point. If you are, am I audible?
Yes, sir.
Am I
Yes.
audible?
Yeah, yeah.
Yeah.
Yes, sir.
So one point only, if you're looking for cytology rather than doing a biopsy of the eye, I would still go for a CSF and a cytospin with a neurocytologist to look for primary CNS lymphoma. Because the way the presentation of the cells is around the disc in both eyes, I'll look at a CNS lymphoma, nothing else primarily. It can't be METs, and it has to be something primarily from the CNS. So we'll do a cytospin of a CSF. That's the only thing I can add.
Nivedita, uh,
Yeah.
yeah, SRB ma'am wanted to know whether fields were done at any point during your workup, and if yes, what was
Uh,
the defect?
I don't remember field being
Not
done,
remember.
ma'am.
I just want to make a point actually. See, in bilateral disc edema, in these inflammatory situations, and especially with suspected peripapillary granuloma, visual field will basically give a clue, whether it is because of raised ICP or because of neuritis, the involvement of the, or papillitis rather. The disc edema is because of the papillitis, raised ICP, or because of just inflammation. That is intraocular inflammation. These are the three causes, usual causes of disc edema, bilateral disc edema. So visual field will be normal in raised ICP or maybe mild enlargement of the blind spot. And if there is actual papillitis and all, there'll be a field effect kind of correlating with it. And inflammatory disc edema, also visual field usually remains normal. Just wanted to add. Thank you.
Yes. Thank you.
Thank you, ma'am. Thank you, ma'am. That was a very relevant point for us to remember to do fields if we are seeing inflammatory disc edema. Yeah.
Yes.
So, what is your final diagnosis, Dr. Niveta, for everybody? We have just pondered
Uh,
over it, but you give us your final verdict.
yeah, it was a case of bilateral granulomatous panuveitis and biopsy-proven definite ocular sarcoidosis.
You
And
can also call
MMS
it
would be the cutoff, right?
neurosarcoid.
Yeah.
Yes, ma'am.
I think, Nivedita, you can present your second case
Yes,
now.
yes. So now we'll proceed to case two. So this is a 62-year-old gentleman. He's diagnosed metastatic adenocarcinoma of lung on targeted immunotherapy agent called afatinib. Um, 40 milligram orally since September 2023. He was started on afatinib from October. The diagnosis for the adenocarcinoma was in September, and he was started on afatinib from October 2023. Patient had two injections of zoledronate because of his bone metastasis, and the last injection of zoledronate was 3 months prior to this presentation. So he presented on 11 May 2024 with complaints of severe pain, redness, blurring of vision, and headache since 3 days. Patient was seen elsewhere 2 days back and was started on prednisolone acetate 1% eye drops 6 times a day, and dorzolamide plus timolol eye drops and cyclopentolate eye drops. On examination, vision was 6 by 24 in the right eye and 6 by 9 in the left eye. So the left eye was normal. He was pseudophakic in the left eye. In the right eye, there is diffuse conjunctival congestion with severe corneal edema with multiple macrobullae and microbullae in the, especially in the superior part of cornea. There were pigmented large keratic precipitates. Sclera was normal. Anterior chamber showed 2 plus cells and 2 plus flare. In iris, there were multiple pigmented iris nodules. We noted iris atrophy from 3 to 4 o'clock position and pupillary sphincter atrophy. The pupil was mid-dilated, non-reactive to light reflex, pharmacologically dilated. Lens was nuclear sclerosis grade 2. AVF details were very hazy because of the anterior segment haze, and intraocular pressure was 48 millimeters of mercury. So the prednisolone acetate eye drops was stepped up to hourly dose for 2 days, and in addition to dorzolamide timolol, brimonidine was also added and was started on tab acetazolamide 250 milligram 4 times a day for 3 days, and atropine eye drops was added. Meanwhile, we discussed with the treating oncologist, and afatinib was withheld. Follow up after 2 days, the anterior chamber reaction was reducing, corneal edema was reducing, iris atrophy was present, and intraocular pressure was 32 millimeters of mercury. So, this is the second visit photograph. So, we can see the multiple pigmented large keratic precipitates, and these iris deposits. There were multiple iris deposits. Here we can see the iris atrophy in 3 to 4 o'clock. The iris deposits are visible here. These iris deposits were present throughout the iris. In the superior part also, these are the iris deposits. Multiple small and medium-sized iris deposits were made out. So posterior segment on the first day of presentation, there was not much view, and disc could just be seen. But in the second presentation, posterior pole view was better. There were no posterior segment inflammatory signs. However, we took an ultrasound B scan to rule out any choroidal or posterior segment mass lesions. So the B scan did not show any choroidal mass lesions. And the RCS, there was no RCS thickening noted or subtenon's fluid. So differential diagnosis is acute granulomatous anterior uveitis with high intraocular pressure. So the first possibility we considered was a viral anterior uveitis, CMV or a herpetic HSV or VZV related anterior uveitis. The second possibility we considered was TB, sarcoidosis, or syphilis. The third was metastasis because he was already a diagnosed case of metastatic adenocarcinoma of lung. And four was drug-induced uveitis, and the insulting agent we considered was afatinib and bisphosphonate. However, bisphosphonate it was last taken for this patient 3 months prior to this presentation, so it was unlikely that it was bisphosphonate induced. So we proceeded with uveitic blood investigations. Mando test was negative, 4 millimeter. Angiotensin converting enzyme level was normal, 39. Quantiferon TB gold test was negative. RPR and TPHA was negative. Chest imaging, there were no new chest lesions. However, he was having adenocarcinoma. We'll subsequently see the radiography images for him. Uh, so bread food was slowly tapered to 3 times a day, and anti-glaucoma medications were continued, but the IOP kept fluctuating between 24 to 56 millimeters of mercury. In spite of good controlled uveitis, this IOP fluctuation could not be controlled on medical therapy. So afatinib was restarted, but as suggested by the oncologist, we went ahead with half the dose as previous. He was on 40. Now we started with 20 milligram orally. And 10 days later, after restarting of afatinib, patient presented with redness, acute pain and headache, and fresh keratic precipitates were noted. AC cells and flare had increased, and iris nodules had increased from before. So this is the radiograph at the time of diagnosis in October 2023. We can see the bilateral multiple lesions in bilateral lung fields. And this was biopsy proven adenocarcinoma of lung with genetic analysis also done. So this the patient presented us to us in May. So this chest radiograph was a month prior. There was as a routine examination, his chest radiograph was due for that month. So the we can see the amazing response patient had for afatinib. So then, because of the uncontrolled IOP and the recurrence of uveitis on afatinib, we proceeded with aqueous humor TAP, PCR, and cytology. It was negative for viruses, and there were no tumor cells noted in the aqueous humor TAP. Iris nodule biopsy also was obtained from the superior quadrant. There was no evidence of metastatic adenocarcinoma. However, there was comment by pathologists regarding melanocytosis of iris, and they recommended to go ahead with immunohistochemistry to rule out any melanoma. So immunohistochemistry was normal, and there were no melanoma cell type detected. So due to uncontrolled IOP on 4 AGM, so by this time patient was also on latanoprost in addition to dorzolamide, timolol and brimonidine. So augmented trabeculectomy with cataract and phaco and IOL was done in July 2024. But post-RAB also IOP could not be controlled. The twice bleb needling was done, but IOP was in mid 30s on 3 AGMs. So, and patient had intermittent severe pain and headache, eye pain due to fluctuating high IOP. So finally, we proceeded with glaucoma drainage device in December 2024. So this is fundus image. The posterior segment was uninvolved. So this is a systemic illness course, August 2023 PET scan showing multiple hotspots in bilateral lung field along with metastasis in the bone and the liver. So this is on afatinib. So we can see like the multiple hotspots in the lung have disappeared. The liver mets have reduced in size. But however, in December, from May to December, the course for afatinib was had to be altered because of his ocular involvement. So we can see a recurrence in the tumor. There is disease progression by December 2024. So, tab was finally stopped because of disease progression, and the patient had to be on full-fledged chemotherapy, and he has completed 5 cycles of chemotherapy. So, final follow-up with this was in August 2025. Vision is unfortunately hand movements. The cornea has pigments on the endothelium, old keratic precipitate pigments. Anterior chamber was normal. AC, there is no active uveitis, and IOP is 11 millimeters of mercury. So, final provisional diagnosis is a probable medication-induced uveitis in the right eye, refractory secondary glaucoma in right eye, glaucomatous optic atrophy in right eye, status post trabeculectomy, and glaucoma drainage device in the right eye, pseudophakia left eye. So, this is a scale we use for diagnosing drug-induced uveitis called the Naranjo scale. So here in this patient, are there previous conclusive reports of this reaction? Yes, for our patient. So did the adverse event appear after the suspected drug was administered? Again, yes, for our patient. Did the adverse event improve when the drug was discontinued? Again, yes. Did the adverse event reappear? Again, yes, for him. Are there alternative causes that could, on their own, have caused this reaction? So, yes, there is viral anterior uveitis and other possibilities. So, -1. Did the reaction reappear when a placebo was given? So, doesn't hold for this patient. Was the drug detected in the blood? Again, doesn't hold for this patient. Was this reaction more severe when the dose was increased or less severe when the dose was decreased? Yes. Did the patient have similar reaction to same or similar drug on previous exposure? Not known for the patient. Was the adverse event confirmed by objective evidence? So we had ruled out all other possible etiologies. So the patient's total score comes to 7, and it is a probable drug-related uveitis. So, drug-induced uveitis is a fairly rare condition with a very low prevalence of 0.5%. But whenever we suspect such a situation, we have to extensively go into the drug history of the patient to identify any possible cause for drug-induced uveitis. So here this patient was on bisphosphonate. However, he was almost 3 months prior to his episode that bisphosphonate was taken. And according to previous studies, uveitis usually develop 1 to 6 days after drug intake, and usually it is bilateral uveitis. So, tyrosine kinase inhibitor, there are previous reports of only one previous report of afatinib induced anterior uveitis. This was a similar case with granulomatous anterior uveitis, but without any glaucoma complication. And it was well controlled after topical treatment. However, another class of same medication, erlotinib, has multiple reports of anterior bilateral anterior uveitis. So usually the ocular side effects of this agent is dry eye, blepharitis or mebomitis, trichomegaly, eyelid skin rash, and anterior uveitis. So challenges we faced in this case was the refractory glaucoma management, and patient had a very good response to afatinib. So considering an alternate treatment for his systemic malignancy was also difficult for us. So question is possibility of a alternate etiology, and how will we go about evaluating such a case?
Thank you, Nivedita. And before we start the discussion for this case, I also wanted to welcome Dr. Mona Khurana, our senior glaucoma consultant. So, ma'am is also around and probably can help us out with the refractory glaucoma part of this case. So, it's over to you, sir and ma'am.
I think Vinita first, ladies.
Go ahead. Go
You're
ahead.
muted.
Go ahead. Go ahead.
Ladies first. Go ahead. Vinita, please.
Okay. So again, Nivedita, very interesting and difficult case when you have drug side effects to think about. But one of the first things that comes forth is that it is a unilateral hypertensive granulomatous anterior uveitis. So that, for the first thing, it will, strikes me as a virus is on top of my list. So viral uveitis. Now, most of the cases reported with drug side effect is bilateral cases. You can have unilateral cases. I have also had experience with dasatinib, where I had a young girl who was being treated for CML with dasatinib. She had also, but it was not granulomatous. It was not such an angry-looking eye. Just a mild anterior uveitis, which was there in one eye. Luckily, because she was in remission, we could take off the drug altogether, and it made no change to the anterior uveitis. So we restarted it. In your case, one of the things I am finding is that when the afatinib was lowered or taken off, still the patient was on topical steroids and anti-glaucoma medication. So probably that would have also contributed to controlling the inflammation and the IOP temporarily. So you may need to consider that when you're looking at the score of the whether the drug is really responsible for this or not. Um, then regarding the other causes, anyway, you have ruled out TB and sarcoid. So those are the other things. Then uh, AC tab, a negative AC tab will not totally rule out viral anterior uveitis. You can, I mean, there are many reports of this also. I think one of the recent reports, Dr. Vivi has published a paper in Taiwan Journal, I think, of this, where he has quite a large number of patients who are clinically viral anterior uveitis but PCR negative. So, but you still can proceed with. You can use that as uh, a reference for starting the patient on antivirals as a precaution, or to try and see if that will reduce the recurrence. Whether it is CMV or how would you treat empirically if you had to treat? CMV will not have such a angry looking eye or so much of reaction. It will be much milder. So you would empirically, if you had to treat also, you would probably treat with valacyclovir as a vis-a-vis or anything. So that is my opinion. Shishir?
Yeah, I think Vinita, I agree with you totally. So for me, let's look at it systematically, and then we'll ask Dr. Kurana's opinion. So the first thing is definitely it is a afatinib induced problem. That goes without saying. that afatinib is responsible for whatever is happening. So because when you stopped it, you had a significant improvement, and when you restarted lower dose again, you had a problem. Now, if you are to look back again, what are the things against afatinib induced uveitis? Did you do corneal sensations for this patient, Dr. Nivedita?
Yes, sir. Corneal sensation I checked, sir, initially. It was
Okay.
normal. Corneal sensation was normal.
So one thing I would have wanted definitely is corneal sensation with so much of involvement. Second thing is the specular. So specular has got very typical pattern and early dropout of endothelial cells on CMV. Okay, the clinical picture is very suggestive of herpetic disease. Not only is it because of hypertensive iridocyclitis, but also there is a sector iris atrophy, there is an iridoplegia, there is a irregular pupil. So, every time you've gone in, you've done a phaco for this patient, you've done a trap, you've done an AGM. I would keep on repeating the PCR for HSV, VZV, CMV every time I went in. I would take that opportunity. I might just get PCR once because the disease has not come in the other eye. And is this just a theoretical thing that we are discussing, or is it something of more importance? I think the importance here is that this patient was doing very well on afatinib, and you have already lost the right eye. Is there a case for restarting afatinib to save his life? Because if it is a virally driven disease and it is not afatinib, purely afatinib, you could restart the drug and save his life. You put him on 5 anti-chemotherapy agents now, and he's not doing as well as he was doing with afatinib. So that is the only reason why we want to harp on it again and again, whether it was a viral disease, maybe induced by afatinib. Some things will come on later. Maybe you have more cases to come in. And definitely, this has not come till now in the left eye, so it's not going to come in the left eye. So if the patient were to approach you and say, look, or your chemotherapist was to approach you, can we restart it? What would be your take, Dr. Nivedita, in this case?
Sir, I would suggest to go ahead with afatinib, sir, because it was now we have lost the right eye. So, but his systemic illness is more concerning here. So, actually, they have four options for the agents. So, gelatinib, and there are few, but his the genetic test is most sensitive for afatinib. So that's why they have like stuck to afatinib. So now again they have done the analysis. They, because starting before chemotherapy they wanted again. So again it is sensitive to afatinib only, it's showing.
And another thing, if you're really up against the wall, is this time for doing an ocular biopsy of the right eye? See, here we are dealing with a patient who is now dependent on a afatinib for his survival. So, is there a case for doing a biopsy, iris biopsy, and again, a more extensive diagnostic procedure on the right eye, and then taking a call for the left eye? That's how I would approach the case at this point. And very nice case, very interesting, and I learned a lot from the case. Thank you.
Thank you.
Dr. Khurana, what would you have to add from the glaucoma
Uh,
point? You have
it was a very interesting case, like a paradox where one drug, it's like saving the life, but taking away the eye. So, one, as a glaucoma person, I would be interested actually in two things. One is initially elsewhere, Predfort and AGM was started directly. So, I would be interested to know from his old records or somewhere what was the baseline IOP and what was the IOP before
Baseline IUP was 56, ma'am.
the first
Baseline
IOP was
IUP was
12%.
56.
Oh, and
Yeah.
then the
The
steroids.
first, like he presented second day to me, like the day before it was started. So it was 56 on the first recording.
And the second thing, which is like really important here, is the gonioscopy, because there was so much pigment on the iris and the posterior corneal surface. I expect the angle to be full of pigment and possibly synechiae. That would again help us decide what the management, like glaucoma point of view, would be. If there are extensive synechiae, unlikely the pressure will come down. If it's gone into secondary angle closure with most of the angles closed. Uh, so we know it's going to end up in a surgery. And if the eyes, of course, since it's a phakic patient, preferably we would start with a phaco and a trap, which was done with mitomycin C. But we make sure that the eye is quiet during the time when we operate and in the perioperative period. In that case, the success is better. But if we feel that the eye is going to be, it's a hot eye, better to go in with a drainage device. I would in uveitic eyes prefer a valve device, but I think cost issue and other issues if you're doing the ADI, because here you want a quick IOP reduction and no hypotony, but I think it did well with the ADI. So that's my take on the other eye gonioscopy. Also, I would be interested to know. Just
Other eye was an open angle, ma'am.
okay.
But this eye we could never have a good view because of the corneal edema. So whenever its IUP was very highly fluctuating. Even if uveitis was controlled, the IUP was kept fluctuating. Some days he would come, it is 24, then we'll be happy. Next day, like some 3 days later, it will be like 40s.
That we
What is
do
triggering
see
this
in
IUP?
uveitis because the ciliary body is compromised, right? It would be compromised. So sometimes these fluctuations are very commonly seen in patients who are uveitis because on one side the angle is closed, but at the same time the ciliary body is not healthy. So there are times when the aqueous production is less, and then you may feel that they're doing well, but when you give steroids and the aqueous production picks up, then suddenly you, plus there will be a component of steroid response always. So I don't know if you tried shifting from predfort to lotipred when the inflammation came down. That could have, like, maybe you could have tried that. But if there was synechia, unlikely that it would have settled. I mean, it would have needed surgery from my point of view, as you rightly did.
And about trabeculitis as a reason, whether that is a possibility, ma'am?
Pardon?
Trabeculitis.
Yeah, usually trabeculitis as well as the extensive pigment blocking it. That's why I was stressing gonioscopy. It's like a combination of there
Yeah.
will be synechia, a lot of pigments, like the way the pigments were on the iris and the cornea. I mean, the angle, even if the pigments go and deposit there, they also damage itself along with the inflammatory process, which causes trabeculitis. And of course, the synechia formation also may have been there. These all like multiple mechanisms, plus some component of steroid response will also be there. All will be there together.
Dr. Nivedita, you must have done an extensive literature search. The earlier
Yes.
agents had bilateral disease. Is that correct?
Yes.
And afatinib
Yes.
had a
It was
unilateral disease. Okay.
unilateral.
Now the case in which the from that was reported on afatinib, what was the type of uveitis that patient had? Did he have synechia?
I think it was reported as a granulomatous uveitis. It was in 2016 that case report has
And
come.
then there will be no
Uh,
case report. So
no case report.
in your case, the one you showed, there were no synechia. So if this
Yeah.
was a uveitis-driven disease causing glaucoma, I would have expected lots of synechia. Here there is a patient with pigment dispersion, sector iris atrophy, trabeculitis, 56 pressure, not responding to anything. And was the eye painful or was it a painless
Painful.
white eye?
It was a painful eye, sir.
It was a painful eye. But I don't
Painful
see
eye.
any synechia either. So if synechia are not there, then again viral disease is not top of line. So there is definitely a afatinib induced disease, but there is also a component of PCR negative, possibly viral driven disease, CMV or whatever. I don't know. I can't say. What do you say, Vinita?
No, CMV, I would say, would be not have so much of a red eye or a
No,
pain.
neither of them have it.
Yeah, so because of the pain and all, I feel that it is more of a VZV kind of a uveitis. And uh, the symptoms along with the unilaterality of the disease in a combined together, I would put that as the first thing. And like I said before, you have taken him off the afatinib, but you're still having the steroids and the anti-glaucoma medication. So you don't really know how much of like lowering the afatinib has really helped him. Whether you can really put
Yes.
that as a score, you don't know. So
Mm.
that is a concern. Um, so yeah.
There's one case report I came across. I mean, it's not a case report, sorry, a study which has been published recently. I couldn't access the full text, which says that it's a retrospective study which looked at the medical data ICD coding, which found that even biphosphonates are associated with the increased odds of angle closure glaucoma. They've not mentioned it's unilateral or bilateral. I mean, you expect it to be bilateral, but I really doubt in that report it was. Bilateral. So that, I mean, I couldn't get the full text, so I don't know, but it was interesting since that patient was on biphosphonate, but they have been stopped 3 months back.
See,
Yeah, they.
I also had a patient who had that with dasatinib. I told you she also had unilateral presentation, but stopping the dasatinib did not make any difference to the uveitis at all. So very mild uveitis. Our concern was more about the cataract she had in that eye, and she was scheduled to go in for a cataract surgery. So we had to rule out or see whether we could control that inflammation or not. But stopping the drug did not. But it was like a very mild, almost like a fuchs type of uveitis with no synechia and no symptoms due to the uveitis per se for the patient. So
Did the patient have KPs, keratic precipitates? Because you could do
My
some.
case
her case or my case you're talking about?
No, I'm talking in your case, yeah, anybody. I mean, because the KP
This
morphology can
case
really
had
guide us about. That's why I was asking specular and confocal. That would really help us non-invasively to decide about a viability.
I think you said Nivedita pigmented KPs were there.
Yeah,
Yeah, pigmented capes.
they're not pigment KPs. They are pigment clumps
Pigment
itself.
out.
Yeah.
It's basically because how why I say it is pigment clumps. You start antiviral and 5 days later everything is gone. The endothelitis is gone, and because the aqueous currents, these pigments are just sticking, just like they are
Yes.
in the angle. And you give antiviral, and you're very surprised to see that everything vanishes as if there was nothing there. So that is probably pigment dispersion with pigment clumps stuck to the endothelium rather than pigmented KPs. And 4 or 5 have remained at the end, which you showed in the heat phase.
So if we have to empirically start, ma'am, how long we have to give the antiviral?
I would have said that you start the proper dose of like valacyclovir and see how the response to treatment is. And once you see the inflammation is controlled and you know that you're probably dealing now with a viral anterior uveitis, then you keep him on a maintenance dose, one tablet valacyclovir, making sure that his renal parameters, all that is all right, and then keep him on a maintenance dose of one tablet till you're fairly sure that it is all controlled. And I don't think apatinib causes any immunosuppression per se, uh, like the other chemotherapies. So, if that was the case, you would have probably wanted to do a CD4 count also and see his immunosuppression also, if that was the case. But here, maybe his the extensive malignancy itself and the long drawn illness that he had, that itself could be the reason for his immunosuppression here. So once that is stabilized, then you can take him off the antivirals also.
And for me, one of the biomarkers with a valacyclovir 1 gram TDS would be smoothing of the intraocular pressures. Like you are having this fluctuation. The first indicator that it's working would not be the going away of uveitis because that is immunologically driven. First would be trabeculitis, and the intraocular pressure would just smoothen out.
Yeah.
What do you say? So I think we have a case to restart Fatinib under, possibly considering that, and you can do an extensive investigation on this eye, which is pre-physical now.
Yeah. Yes.
Any more
There,
pearls of wisdom from our panelists? SRB ma'am, MAK ma'am.
there
Anything
are
else
so
you'd like to
many.
add? We had a wonderful discussion.
Really amazing discussion. Great points. I learned a lot.
Very
Thank
encouraging,
you.
man, for the whole
Thank you
group.
so Thank
Very interesting cases. That is the thing. And these cases walk into your clinic, but how you approach them and how you work them up and how much you follow them, that is the thing. The presentation of a case is not the important thing. How you pursue it and how you look after them. That's more important. That's what SNS taught us.
Really very nicely worked up, documented. Really,
Thank you so much.
congratulations. Congratulations.
Thank you. Thank you, sir.
So we can see some old friends of ours. Hi, Vijay.
Vijay sir is here. Hello, sir.
Vijay is there in every powwow. He makes sure one Seema madam from US, she joins every time.
She's there. Yeah, I
Yeah,
give
she joins
but,
every time, and Vijay is there 110%. He's every time there, be it Uvea, Purnia, anything, he's there. Great.
You can put on your
Hey, Dr.
headset.
Seema.
I can.
Thank
Can
you,
you hear
Wonderful
me?
to
ma'am.
see
Thank
that.
you.
Archie,
Wonderful to see you
can
young
you ask
physicians
everybody
working
to put
so
on their
well and
videos?
taking care of patients. Keeps Netralia very proud. Keep doing
So
Thank
this.
you. Thank you.
Thank
Thank
you.
Thank you.
you.
request
Thank you,
everyone to
sir.
put on their videos so we
And
can know what they
Shikha
are.
for organizing this goes very good.
Thank you. Thank you, ma'am.
Thank you. Good night.
I would like to invite MAK ma'am to please give the vote of thanks
Yeah.
for tonight's meeting.
Okay, I'll also give my summary
Yes, ma'am,
and
please.
then the vote of thanks. So we had two very interesting cases today. So one was like a gallery of granulomas and nodules where TB is always lurking in the wind, but sarcoid is always at the back of your mind. Syphilis is the great impersonator, and tumors can sneak in anytime. So what we learned here was that in case of sub-RP nodules, the causes can be multiple, like Dr. Vinita told us, sarcoid, serpiginous, multifocal choroiditis, but you have to see it in conjunction with the clinical features. Like if it's later age, you don't suspect VKH, and posterior synechiae are less likely to be there with any infiltration. Um, and vitreous biopsy, you should always take after stopping steroids for 2 weeks. And it's indicated if there's blurred vision, which is a predominant symptom. There's mild anterior uveitis with synechiae, and the response to steroids is just waxing and waning. And Dr. Shishir told us how to put together pieces of the puzzle, and if something doesn't fit, then you have to keep on looking. For example, in the first case, there was vitiligo, CSF, pleocytosis. I think the macular edema was not fitting in because there was disc edema, which is not seen in elderly, where macular edema is seen, which was not there. So you need to keep on looking, and make all the pieces of the puzzle fit. Octa, he suggested, should be used for a baseline as well as to monitor. You can add it to your armamentarium. So VKH was a top contender, but ultimately it was sarcoid, and sarcoid can also transform to lymphoma. So long-term follow-up is required. So for the second case, it was a secondary glaucomatous uveitis, which was due to something very paradoxical. The drug which was saving the life, but could not save the eye. And again, the viral was again the contender here. And I think the consensus was to do all the investigations, follow up closely, and once you withdraw the drug, look at the response, and the final consensus was to restart the drug, as it's mostly viral, if I got it right. So, and I would like to thank Dr. Niveta for the wonderful cases, Dr. Vinita and Dr. Shishir for the excellent comments, Dr. Arshi for moderating so gracefully, Dr. Shikha for organizing, and all the Dr. Seema and Dr. Vijay and everybody for attending the powwow today. And we look forward to another powwow. And thank to the multimedia also. And
Thanks everyone. It was
Thank
a
you. It was a
Thank
wonderful.
you. Good night. Thank you. Thanks a
Thank
lot.
you so much. Thank you for the opportunity. Thank you.